The best for the last. Over to Dr. Titiyal, teacher, surgeon, administrator par excellence. Over to you.
Thank you very much. I think I would like to show some of surgical intraop difficulties which we create and makes things difficult. And this is one case. I was operating, things are going quite appropriately correct. Emulsification is being completed here. And you can see I'm trying to aspirate the cortex here. The cortex is being aspirated. Just keep see what is happening here. So this is what has happened here. The entire bag has come out. So this is a time where we have to think what has happened here. Though PC is intact, I'm injecting the dispersive viscoelastic from the other hand and using the tamponade effect of a dispersive viscoelastic, then doing an aspiration bimanually now to complete that aspiration. The only thing what we have learned here is to identify the bag dialysis happening because you have your hold has been little challenging here. I was holding both capsule as well as the cortex also while pulling. So this is how the rescue measure here. Dispersive viscoelastic was helpful. Bimanual aspiration did a wonderful job for this. Then subsequently placing CTR and IOL implantation. I'll go to the next case, which is also similar case here. I'm doing a aspiration of cortex here, done the complete aspiration. And I thought everything is complete now, injecting the IOL. So you do have a little fibers here. As we discussed, Dr. Ram was talking about hydro, cleaning of a posterior capsule. Sometimes I use my, optics of the IOL to take out the, these fibers. And this time when I'm doing this, the entire bag got dialyzed at this stage also. You can see the bag dialysis happening here. So you can produce these little changes, and sometimes it can be difficult if you are dialyzing a little bigger. So this is, again, I'm not leaving that like that. I'm putting a CTR underneath the IOL to maintain the bag distension in a uniform manner and getting the IOL to remain well centered in the bag also. So these two difficulties I did face before I shift to next case. Any comments from the panel?
I think something like this, Dr. Abhay also showed.
Okay.
Just a small tip. I mean, anything you do for removing epinucleus with your phaco probe itself.
So there, I think your phaco parameters should be under your control, and your foot pedal is the main concern. Make sure if your fibers are visible, and initially you should make sure your hydro dissection was proper. If your hydro dissection is good, you can do easily this process. If your hydro dissection is poor, then never attempt this because it will be difficult to pull those fibers. So it is when you are confident, you are comfortable, then do it. Otherwise, leave it. Okay, let me go to the next case, which is a person with high myopia with nuclear cataract. I thought I can do a routine surgery here. I stent the capsule, around 5 millimeter capsular is being done. Good hydro procedure. And things are looking quite all right. Nucleus could be rotated. I'm doing a routine. It is around grade 4 plus phaco. Initial chop was done effectively. Rotation happening. And another chop is being done here. So multiple chops normally I prefer in these cases. Now see that when I'm trying to take out, the entire bag is loose and moving. And this is a stage where I got worried. So let me put this question to Dr. Ram. What would be your approach at this stage when the entire bag is loose?
I would maybe put an endocapsular ring in place right now, and then secondly, create that. I don't think your nucleus fragments are completely separated. So I'd go ahead and create a deep trench and maybe go with 2 Sinskey hooks and separate them into 2 heavy nuclei and then very gently remove them.
Capsular hooks. Capsular hook on the capsule.
Okay.
Only capsular hooks or endocapsular.
I think first step would be capsular hooks. That itself will stabilize the bag. Then you can plan about the CTR.
So I agree to Dr. Chitra here because I have to agree with her only. So I'm doing the same. Once your bag is totally loose and it is, your nucleus is not being rotated, so both can be there. You can put CTR as well, and you put capsular hooks. Both can be put at this stage also. I prefer to put hooks there to stabilize the capsular bag, and normally around 4 or 5 hooks will, because this is an entire loose bag. Just putting 2 hooks may not suffice. So I have a stronger hold here and stronger. These are 2 axes where you're going to have more this thing. And Dr. Ram was suggesting I'm trying to separate the central piece here. Now I could separate the central area. Now I can take out the pieces very effectively also. So I could complete the phaco effectively subsequently. I'll just go a little faster and aspirate the cortex with the bimanual aspiration. And make sure your bag remains, this is a loose bag, so you can damage the posterior capsule also. And there, maintenance of anterior chamber is very, very effectively should be done. Always when a loose bag is there, bimanual aspiration really is a good help in these cases also. So at this stage, I thought, what should I do? This is a high myopic patient, as such required the expand range of IOL. So what will be your idea, Dr. Abhay, to implant the lens? Should I implant the lens in the bag, or what should I do? Dr. Chitra. Mic.
First, you should put a CTR at this point of time.
Okay.
It is a loose bag.
Yeah.
So then only you can remove your hooks.
Yeah.
So after you place your CTR, then you can loosen your hooks, and then you could place your lens.
Okay.
And if after that you feel that the lens is better off not in the bag and your axis is smaller, then you can even do a reverse optic capture.
So I didn't put a CTR in this particular case. I'm putting lens in the sulcus. Haptics will remain and getting the optic capture done in the anterior capsule for stability. CTR should have been one option here that I missed in this patient. Good option. So I'm trying to rotate the haptic into the sulcus and trying to get, because this is a very, very loose bag, the entire lens was moving. Then I get to the capture into anterior axis. So these are 2 combination, haptic in the sulcus and optic capture in anterior capsule in a high myopic patient. Subsequently, I put a suture and completed this surgery. Yes, Abhay, you wanted to make comment?
That's what I was going to tell you. But I sometimes I'm tempted to do capture also, because this is a loose bag, and you're depending on this loose platform. Even if your haptics in the sulcus is not going to, IOL won't be shifted because they are fixated in this thing. So if you doubt if the capture is not that good, you need a decent capture, anti-capture. If it's not there, PCCC also.
Yeah, I think that would have been a better idea to capture both anterior posterior wise. Thank you, Abhay, for nice comments, and thank you, Dr. Ram, for giving me this opportunity to be with you. Thank you.